of today's presentation. As you all know, the biggest health problems in Maldives are cardiovascular diseases, then thalassemia, and then tuberculosis, and then after this it's chronic renal diseases, chronic renal insufficiency. 10% of population of Maldives has this problem. And tonight, Dr. Mladen is going to tackle this problem with introduction, a short introduction about the problem, and then review possible solutions. And these solutions, 3 or 4 of those solutions, that we will discuss after his presentation. So, Dr. Knotek, please.
Thank you. First, I would like to thank colleagues from Treetop Hospital who made this CME possible. And I would also like especially to welcome our dialysis nurses who made dialysis in Treetop Hospital possible. And because I think these days is first anniversary of dialysis at Treetop Hospital. So thank you for coming. How many of you are involved in care of kidney patients? Do you work on dialysis? Excellent. And is someone a nephrologist here? No. Okay. So I would like to briefly give an overview of renal replacement therapy as an integrated field. As we all know, chronic kidney disease worldwide is very frequent. This table shows percentage of, I don't know how this works. It doesn't work. Sorry? Can we turn off one of the lights? No, it's not working. Never mind. This table shows prevalence of chronic kidney disease. It's stage 3 to 5 worldwide. If we look at the box here, in majority of countries, this prevalence is between 6 and 15%. And I would say that in most countries, it is closer to 15% because some countries' statistics are not complete. And based on this data, Maldives should have somewhere between 28,000 to 40,000 patients in stages 3 to 5 of chronic kidney disease, which is really a lot. Sorry. If you look at causes of chronic kidney disease, in majority of countries, diabetes, hypertension, and then glomerular diseases prevail. In India, for example, this is shown here, and probably similar should be in the Maldives. Diabetes and hypertension are most frequent causes, followed by glomerular nephritis. If you look at renal replacement therapy, which is therapy that is reserved just for terminal chronic kidney disease, then we can speak of 3 basic modalities: hemodialysis, peritoneal dialysis, and kidney transplantation. Each advanced society should have access to all of these modalities, and this access should be equal. These modalities should be viewed as complementary and only as stages or phases in integrated renal patient management. And informed healthcare providers, nurses, and physicians, as well as informed patients, should make decisions about treatment. And in the Maldives, you are lucky that renal replacement therapy is universally reimbursed to patients. This is not the case in many Asian countries. So Maldives really achieved a lot in treatment of end-stage kidney disease. I will use some data from European Renal Registry in this presentation, because this is a large registry that consists of data provided by many European countries, and it's illustrative. So in Europe, incidence of end-stage actually incidence of renal replacement therapy has plateaued in recent years. It's not increasing anymore. And actually, incidence of end-stage kidney disease is decreasing in many European countries. But prevalence of patients on renal replacement therapy, this is second graph, is increasing. So more and more patients are on renal replacement therapies each year. And this is because these patients live longer and longer, fortunately. In the Maldives, there are 10 hemodialysis units in other hospitals and one dialysis unit here, so total of 11 units, around 300 patients, which gives prevalence of dialysis patients of approximately 678 per million population. And if Maldives would be in Europe, it would be somewhere here. But this data also consists of kidney transplant patients, and I wasn't able to get data how many kidney transplant patients are there in the Maldives. I would say significant number, but based from my experience from renal clinic, but I don't know how many. And number of patients on dialysis in the Maldives is increasing. These are data provided by, I think, Ministry of Health, showing that from 2016 to 2018, that number of patients on dialysis is increasing. This is also consistent with European registry data, and we can expect that this number will continue to increase. So we have 3 renal replacement therapy modalities. What is the optimal renal replacement therapy? These 2 graphs show survival curves on dialysis and after kidney transplantation. And when we look at these 2 graphs, it is very clear that patients after kidney transplantation, this is right-sided graph, they live longer than patients on dialysis. 5-year patient survival on dialysis is less than 50% in Europe. Similar data are from United States. But 5-year patient survival after kidney transplantation is higher than 90%. So compared to dialysis, kidney transplantation is superior renal replacement modality. Although when this all graphs would be adjusted exactly for the characteristics of patients, probably this difference would be a little bit less. But unfortunately, even transplantation does not provide same survival as in healthy population, and in all age groups, regardless of the method of renal replacement, patients either on dialysis or after kidney transplantation live shorter as compared to healthy age-adjusted population. And this is what needs to be addressed in our everyday practice and in research, how to prolong survival of patients on renal replacement therapies. This is a major issue. If we compare survival of dialysis patients, for example, with patients with malignancies, dialysis patients have survival that is, for example, better just than survival of patients with pancreatic or lung cancer. So survival rates on dialysis are similar to survival rates of patients with advanced cancers. And unfortunately, also some native origin, some causes of kidney diseases, of end-stage kidney disease are associated with lower survival than the others. For example, patients with diabetes have lowest survival on renal replacement therapies, regardless of the modality. So even kidney transplant patients with diabetes have lower survival as compared to kidney transplant patients without diabetes. So why is patient survival on dialysis suboptimal? Patients have significant comorbidity. Frequently, they are quite old when they start dialysis. For example, in my country, median age of patients starting dialysis is 67 years, and average age is even, I think, a little bit higher than that. And dialysis is imperfect method of renal function replacement, and of course, dialysis practice is sometimes suboptimal because of dealing with some problems with patients on dialysis, such as vascular access, dialysis intensity, following dry body weight, electrolytes, and so on, blood pressure. I will now talk a little bit about some aspects of dialysis and then on transplantation. So as we know, hemodialysis is performed in such a way that blood flows in opposite direction to dialysate, and they are separated by semi-permeable membrane, which according to characteristics of the membrane can be permeable to different solids from the blood. And in its classic form, the oldest form, these filters, dialysis filters, were low flux filters that provide very good clearance of low molecular weight molecules, but unfortunately they are not very permeable to middle-sized molecules, and these middle-sized molecules are associated with some long-term complications of chronic end-stage kidney disease, such as beta-2 microglobulin amyloidosis. High flux hemodialysis, which represents quite advanced from low flux, enables clearance of medium-sized uremic toxins and provides advantage. In many countries, high flux hemodialysis is a standard of hemodialysis care. Hemodiafiltration, something that we do here, is further advanced from high flux hemodialysis. It's renal replacement therapy that combines diffusive and convective solute transport. It uses high flux membrane, and this high flux membrane have very high permeability, so that we can apply infusion of 17 to 23 liters of water during 4-hour session of dialysis. Obviously, machines that perform hemodiafiltration need to be sophisticated machines that can very precisely calculate ultrafiltration, because all of this volume, huge volume that is administered in 4 hours should be removed from the patient. And water for hemodiafiltration should be ultra pure water, because contamination of water with either some impurities or with bacteria, endotoxins, can lead to significant adverse effects of hemodiafiltration. So this is schematic representation of hemodiafiltration. We have classic high flux membrane, which is permeable to low and middle-sized molecules, and we also have infusion of high volumes of substitution fluid. The substitution fluid is prepared by the machine itself from the tap water from tap water, right? And it provides very intense treatment. So high volume only hemodiafiltration is currently the most advanced renal replacement therapy using extracorporeal circulation for treatment of chronic kidney disease. And in many countries, it has become standard of dialysis care. It has proven to be more beneficial for patients. For example, this French registry study with 25,000 patients showed that risk for all-cause mortality or cardiovascular mortality in patients treated by hemodiafiltration was lower than in patients on regular hemodialysis, and that was also significant in many subgroups of patients that were analyzed. Similarly, in a meta-analysis of randomized controlled trials, mortality on hemodiafiltration was also lower as compared to hemodialysis, and this reduction was especially noted when cardiac mortality was analyzed. Why could hemodiafiltration be better than hemodialysis? These are some answers. Prevention of left ventricular dysfunction, improved blood pressure stability, which helps to deliver higher dose of hemodialysis, better clearance of middle-sized uremic toxins, because this convective, this huge volume of infusion of fluid helps to clear more middle-sized molecules, then decreased inflammation and improved vascular endothelial function in patients treated with hemodiafiltration. These more intense therapies, like high-flux hemodialysis and hemodiafiltration, would be expected to be particularly beneficial for patients expected to remain on dialysis for a long time. If we plan to transplant patient very soon after starting dialysis, it's irrelevant what kind of dialysis is the patient on, because expected time on dialysis is short. But for example, for somebody who doesn't have a donor or who for any reason is not a candidate for transplantation, hemodiafiltration or high flux dialysis are actually mandatory, because they would prevent development of some chronic complications such as beta-2 microglobulin amyloidosis, which is a very big problem in dialysis patients. And development of these novel therapies or more intense therapies has been associated with improvement of survival of patients on dialysis, as seen here. For example, as compared to 1990s in last century to today, there is steady improvement in patient survival, which correlates with introduction of these more sophisticated and more intense methods. I cannot conclude that only these methods are responsible for this improved survival, but there is an association between their introduction and better survival of dialysis patients. But if you still look here, even in this newest era, 5-year survival would be just 45%, which is quite low. Peritoneal dialysis is another modality that doesn't need access to circulation. It needs access to peritoneal cavity, and peritoneum serves as this membrane that separates the body from the dialysate. It can be done in two ways. One is manual. It's called continuous ambulatory peritoneal dialysis, or CAPD. This is shown here. Patient performs exchanges by herself or himself. And the other one is automated, using a machine, a cycler, and the method is called automated peritoneal dialysis, or APD. It's performed usually overnight when the patient is sleeping. This machine performs several exchanges of fluids and performs dialysis. There are very significant differences in peritoneal dialysis as compared to hemodialysis. Peritoneal dialysis is performed at home, in home of patient, while hemodialysis is usually in-center, although in some countries even more and more patients they have hemodialysis in their houses. It can be done by the patient outside of center as well. Then patient engagement and independence is high in peritoneal dialysis. They don't need to go to center. They can do it at home. They're completely responsible for treatment. They can decide when they would like to have it. while of course hemodialysis doesn't provide this patient independence. Negative impact on quality of life is much lower in peritoneal dialysis than in hemodialysis because patients can travel wherever they want. They are not bound to these hemodialysis centers. When patient wants to travel somewhere, these solutions for dialysis come with the patient. They are delivered to address where the patient says he would be. There is continuity of renal function replacement in peritoneal dialysis, unlike hemodialysis, which is intermittent. In that way, peritoneal dialysis mimics renal function. Less acute adverse effects of the procedure. Unfortunately, there are some important complications present in both modalities, and this is infection. In peritoneal dialysis, the major infection is peritonitis. In hemodialysis, it's bloodstream infection, especially if the patient uses dialysis catheter as vascular access. Then peritoneal dialysis has much lower hemodynamic impact than hemodialysis. For example, peritoneal dialysis is excellent modality for patients with liver disease and for patients with heart failure. Peritoneal dialysis has much less electrolyte disturbances. Unfortunately, it's associated with a little bit higher incidence of hypervolemia than hemodialysis. Very good thing is that it is associated with longer and better preservation of residual renal function than hemodialysis, which makes handling of this hypervolemia much easier than in hemodialysis. And cost of peritoneal dialysis in almost all countries is lower than hemodialysis. Peritoneal dialysis is cheaper. And sometimes this peritonitis is a feared complication of peritoneal dialysis. These are data from my center, and we showed that actually patients who experienced peritonitis didn't have at all lower survival than patients without peritonitis, and there was even tendency for them to have better survival on peritoneal dialysis, probably because they were better controlled, better followed up after an episode of peritonitis. So this is not surgical peritonitis, and we don't need to fear it. And when we finally compare survival on...
I'm trying to find you on Facebook.
Yeah. When we compare survival on peritoneal dialysis with hemodialysis, these survival rates are equal. So peritoneal dialysis is not inferior method to hemodialysis. This is very frequently heard on events. For example, in Europe, sometimes it's equally good method as hemodialysis. There is very large difference in prevalence of peritoneal dialysis between different countries. For example, in Hong Kong and some parts of Mexico, prevalence is very high. In some European countries, northern countries, approximately 20 to 30% of patients are treated by peritoneal dialysis. Similar situation is in Australia and New Zealand. But in some countries, prevalence is very, very low. In some countries, there is resurrection of peritoneal dialysis, for example, in the United States. And during last several years, in many countries in Europe, for example, peritoneal dialysis is attempted to be established as actually the preferred first dialysis modality in patients who are eligible for it. So peritoneal dialysis is especially suitable for geographically disadvantaged patients. This would be the case for the Maldives because people live in many different islands far from dialysis centers. They frequently need to relocate to Malé or somewhere else to have hemodialysis, and if they would be able to do peritoneal dialysis on their islands, their homes, it would be very, very good, and we at major centers would be able to control them by telemedicine, because all of these, for example, devices for automated peritoneal dialysis, they have internet, they can have internet access and data transfer, so it wouldn't be difficult at all for them to do peritoneal dialysis in their homes and for us to follow how they are doing it. Peritoneal dialysis is excellent for younger patients, especially employed patients who wish to be independent in their renal care. They can perform exchanges in their offices, other working places. And of course, it's very good for kidney transplant candidates, also, especially for people who are waiting for deceased donor, because one of the problems with deceased donor kidney transplantation is frequently delayed establishment of kidney function. So during that period, peritoneal dialysis patient who comes to transplantation with preserved residual renal function helps to avoid early dialysis. Transplantation is the only renal replacement therapy that almost fully restores normal renal function. Not completely, but almost fully. Transplantation allows that dialysis can be avoided in some patients. In some European countries, 15 to 20% of patients, even without a living donor, they start renal replacement by transplantation. This is called preemptive kidney transplantation. Transplantation is the most cost-effective renal replacement therapy. It is more expensive as compared to dialysis only in first year in majority of countries. Afterwards, it's much cheaper than dialysis, and it is associated with best survival rates as we saw. Many patients can be candidates for transplantation. For example, this graph shows what percentage of patients on the wait list or have received kidney transplantation in the USA in different age groups. And for example, in younger age groups, up to almost 60% of patients can be transplant candidates or can receive kidney transplantation. I would even say that this is very conservative. And some studies have shown that even 50% of patients on dialysis can be transplant candidates. In the Maldives, I have impression, I don't have data, but I have impression that average age of patients on dialysis is not that high. So here, I think very high percentage of patients can be candidates for transplantation, especially those who are coming to dialysis, who are not on dialysis for a long time. This I have already shown. Patient survival after transplantation is much better than patient survival after dialysis. This graph shows how in countries with a large number of kidney transplantation, number of kidney transplant patients grows. And for example, here are data from my country that this graph shows how with time percent of kidney transplant patients has increased. This is yellow. So that now this has stopped in 2015. If we would look up to 2018, much more than 50% of patients who have replacement of kidney function, they are actually transplant patients. We have decrease of number of patients on dialysis in Croatia. And that can be achieved, I think, in the Maldives as well. So again, the same sentence as in the beginning. Renal replacement modalities are complementary. Choice of renal replacement therapy should depend on availability, but there is no reason why in the countries like, for example, Maldives, all modalities would not be available equally. Of course, informed patient preference is crucial for choosing modality of renal replacement. Physician preference for a particular patient together with the patient as well. And society always needs to decide where to invest effort. And in here, I think it would be very good to invest more in kidney transplantation in the Maldives and in establishment of peritoneal dialysis program. So once again, the same scheme, similar scheme. All of these modalities as complementary modalities. Transplantation should be ultimate goal of renal replacement. It can be first dialysis modality. It should be first modality in all patients that don't have contraindication for kidney transplantation and when they have suitable donor. Frequently we find here that the patient has a donor who cannot donate because of, for example, some histocompatibility issues, like the patient has formed antibodies toward the donor. But in that case, we can also do transplantation either as incompatible transplantation with certain procedures that would allow us to do such transplantation, or with donor swap. Patients can exchange donors. And from one donor recipient pair that is incompatible, we now can have two pairs of compatible donors, and instead of performing no transplantation, we can have two transplantations. So this is actually very easy to establish and to do. Peritoneal dialysis should be second probably option if transplantation is not available. It should be first option for patients who live far from hemodialysis center, and hemodialysis center will remain most prevalent dialysis, or even most prevalent renal replacement modality. And how years pass, patients get transferred from one modality to another. Kidney transplant survival, average survival is today maybe 15 to 20 years. We can expect that the patient will live longer than that. Before transplantation, patient can have dialysis. After transplantation, for example, can have another dialysis modality, then receive second transplantation. So all of these renal replacement therapy modalities are actually these different phases or stages in the management of patients with end-stage kidney disease. But kidney transplantation should be first, if possible. So again, as a conclusion, all renal replacement therapies should be available. Complementary methods, we need to use as much time as possible, if we have that time, for patient education. I try to show patients small videos in my office when I have time. I want to educate them about different ways of replacement of kidney function. Afterwards, they have many questions. Before that, there are no questions. Peritoneal dialysis should be preferred dialysis method for patients who live far, or for those patients who need more autonomy. And preemptive kidney transplantation should be promoted as the best renal replacement, especially for younger patients who have readily available donors. Thank you very much.
Thank you very much, Dr. Knotek. Now, the second part, do we have any questions? I think that Dr. Knotek emphasized clearly what are the problems, what are the decisions that health authorities, doctors in Maldives have to make. Decision is regarding which type of kidney replacement therapy is the best. And perhaps the question for Dr. Knotek, what is the position of health authorities in Maldives regarding this question? answered tonight, and I would like also to engage all of you to tell us your opinion. What do you think? Which type of kidney replacement therapy is the best and why? I do understand indications for certain types of kidney replacement therapy, but these are individual. What about health authorities? Do you have something to say about it?
Yeah, we approached health authorities with this question of peritoneal dialysis, and I was very satisfied. I was satisfied to get a very positive answer from Ministry of Health. So I hope they will form a task group on peritoneal dialysis, because this can be very easily established, and it would be, I think, very good for patients. I don't know, I've been here for less than 3 months. I don't know if it would be possible would there be any problems in establishing a kidney transplant program in the Maldives, because I don't think that it is very good. I don't think it's an optimal way of transplantation that patients have transplantation abroad, because the centers are far away. They cannot receive patients immediately if there is a complication, and it's even more expensive for health system in the Maldives if the patient needs to stay, for example, for 6 months in India to wait for transplant, to get transplant, and then to be followed after transplant. It should be easier to have this transplant here. I don't know what do you think? Would that be possible? Would patients accept it? No. Why do you think?
So there's psychological issues up there. They are more comfortable in India rather than having here.
But psychology can be changed if patients believe that a program can be successful, and if such program is established. So I don't know. Yes?
I think actually I have worked as a nurse in hemodialysis for the past 15 years. From the initial stage, the dialysis has been opened. Recently, in year 2017, we in IGMH, we have started peritoneal dialysis, but around 2-3 patients we have started, and then we brought the fluids also. We have also sent 2 nurses, and the doctor has been also trained. But I don't know why patients doesn't want it at all. Probably because the way we started, I have no idea why it has not gone the right way, because patient doesn't like at all. Those 3 patients.
CAPD?
Yes, CAPD. And regarding the transplant, we have very few donors. People don't give most of the people, they don't have the relative donor. So that could be a reason also that it has not been started. I'm not very sure. And at the moment we have 1 nephrologist in IGMH, 2 nephrologists in IGMH. So they are trying to start it, but so far I think the legal thing and so many things we have to prepare. So that may be the reason it's not started. I'm not very sure about it.
Yeah. Well, with peritoneal dialysis, I come also from country which is not very populated, but we had 40 dialysis centers, 40, and this proportion of patients on peritoneal dialysis was fluctuating during years. And some centers, like for example my center, we had 50% of patients on peritoneal dialysis. And nobody was, of course, forced to choose peritoneal dialysis. But if the patient sees realistically how peritoneal dialysis is done, how hemodialysis is done, I don't know, if I would need to be dialyzed, I would prefer to have peritoneal dialysis because then I can manage my own time. I can do it in my own way. And in that case, you get, if you present it like this and you have firm data that shows that survival rates between these two dialysis modalities is equal, then many patients would choose peritoneal dialysis. But for example, in some dialysis centers, we couldn't achieve that even one patient started peritoneal dialysis. And patients are always the same. This is not due to the patient. I think this is mainly due to how the patients are approached and how are they educated.
I think it is also very important. I mean, especially when we have small kids. Right now also we have very small kids. Sometimes because this PD is not available, it is really very difficult for us also, because always patient is having the catheter and this is going on, but maybe we have to put more effort.
Yeah, for kids, peritoneal dialysis is even more important than for adults. It's even better than in adults. I think education and very early talk about renal replacement in renal clinics. Because when people start to get educated about their disease and their prognosis early, they will have more time, and we will have more time to prepare. They won't achieve end-stage kidney disease unexpectedly, and then you rush to get vascular access and everything. If you do it early enough, in a timely manner, and if everything, the other very important thing is everything, the logistics of peritoneal dialysis should be present. Patients should not think even 1 second where do solutions come from, how solutions will come to their house, who will pay for them. So this all needs to be sorted. And this will, with all of this, it will be cheaper than hemodialysis for us and I and for patients, for everybody. So this is, I think, something that needs to be arranged. State should be, or I don't know, state health agency should be responsible for these things. Patients just, care of patients should be just to connect and disconnect, and to come once a month or once in 2 months for follow-up visit, nothing more. And in that way, they will choose peritoneal dialysis, I'm sure.
How about the infection rate?
Sorry?
How about the infection rate?
Infection rate. For example, one peritonitis episode in 20 months. But if the patient is properly trained, they would recognize it immediately. They even can have one ampule of vancomycin in their home. And they take a small sample of dialysis fluid for analysis. They bring it next day to community clinic or somewhere else. In the meantime, they can put vancomycin into the bag, and they are cured, because vancomycin in kidney patients acts very long. So peritonitis is never a problem if the patients are well trained. But if the patient develops episode of peritonitis, the patient should restart training because something was wrong. For example, in my country, we had one patient who was traveling between Croatia and Kosovo, another country, and the patient used to make his exchanges in gas station, in the toilet of gas station. Of course, this is not clean place where exchange of peritoneal fluid should be done. And he got peritonitis. But he got re-educated and he stopped doing it, and it was okay. Yes?
With regard to donors, how fit can the donor be after donating one kidney? Because I come from the army, so they have to do physical exercises post donating the kidney. So I'm just asking, how fit can the person be?
Have you heard of Ivan Klasnic, who was Croatian football representative? So he received 2 kidney transplants, and he was playing professional football afterwards. So it is possible, yeah. Because kidney donors, in order to be donors, they are selected so that they are completely healthy. Yeah, I understand. After surgery, this is not that big surgery. They need some time to recover, and then they can do their physical work normally.
Can I ask one question regarding this health problem generally? 40,000 patients, and how many nephrologists here in Maldives?
Yeah, I think we are 3 now.
On 40,000 people.
Yeah, this is not enough. Yeah. There should be at least 10 nephrologists in the Maldives. Yeah.
There's a FP Live question. It says, is Treatop capable of treating an infant on hemodialysis?
Excuse me, I didn't understand.
There's a FB Live question for you. It says, is Treatop capable of treating an infant?
Of treating? Infants. Yes, we don't have pediatric nephrologists, but there are no pediatric nephrologists in the Maldives. But we could do it, yes. Yeah.
Therapy replacement, renal replacement is the transplantation.
If possible,
and
yes.
What are the criteria for select the patient for kidney transplantation, or all the patients can be transplanted?
Well, there are contraindications for kidney transplantation. So I will say first what are not contraindications. Age is not a contraindication. Then a previous history of certain diseases, like past history of infectious diseases, past history of tumors, if they are cured, this is not a contraindication. Contraindication is active malignancy, active infection, and that's it. So, and of course, very, very poor cardiovascular status. For example, advanced coronary heart disease that cannot be corrected, or congestive heart failure, or decompensated liver cirrhosis. But in majority of patients, kidney transplantation is not contraindicated, and that they can be transplant candidates, especially for transplantation from living donor, because these are lower risk transplantations than transplantations from deceased donors.
Renal transplantation is better than the survival benefit
Yes.
compared to the hemodialysis. So that was for the living donor, right?
No, this graph stems from Europe. In Europe, majority of transplants are deceased donors. In living donors, it would be even better.
It will be even better.
Yes.
Any more questions? If not, Dr. Knotek, thank you very much for your presentation, and thank you all for coming. There's one more FB question.
Okay, this question is from Deepak Mokhtan. Peritoneal dialysis fluid for pediatric age group is available in Maldives. He is asking.
Peritoneal dialysis for pediatric patients.
Pediatric age group is available in Maldives.
It will be available soon, I think. Yeah, because this should be first dialysis modality in pediatric patients, especially in young children, small children.
Okay, if no more questions, thank you very much,
Thank you.
Dr. Knotek, and thank you all for coming. And please have a coffee. Here. Dinner. Dinner. Okay. Okay. Thank you very much.
Thank you.
I listened to 10 even from